at Carolinas Medical Center. Glad to be here with you tonight. All author disclosures are listed here. So as many of you know, fracture-related infections are challenging for all parties involved. Even when the diagnosis is clinically obvious, as seen here, treatment is often costly and time-consuming, and also disheartening if unsuccessful. Treatment of deep infection in the setting of ununited fractures is often treated in a staged fashion, consisting of 2 or more surgeries, since treatment of infection, eradication, and fracture stability are often difficult to achieve simultaneously with previously established treatment options. So the first surgery typically prioritizes treatment of infection by removing implants and introducing local and systemic antibiotics. After a full course of antibiotic treatment, typically 6 weeks or longer, a second surgery aims to definitively restore long bone stability through operative fixation, similar to that of the index injury. So as an alternative, some authors have previously proposed a single stage treatment approach by coating a locked intramedullary nail with antibiotic cement. The purpose of our study was to assess the safety and efficacy of our unique antibiotic nail recipe, specifically designed for simplified fabrication and minimal cost for paramount external validity. From 2015 to 2019, we enrolled consenting adult patients presenting to our institution treated with an antibiotic-coated locked nail. Although coated nails were used during this timeframe for a variety of indications, we limited the scope of our study to patients with a deep infection plus ununited fracture treated in a single surgery. Infection was based on clinical signs and/or abnormal lab values. Status of fracture union was determined radiographically at the time of presentation. Patients were included for analysis if the locked intramedullary nail coated with antibiotic cement was used to treat their infection, as I said, in a single procedure. The senior author of this project established the recipe and technique prior to study initiation and disseminated it across the department to interested attending trauma surgeons. All coated nails were fabricated intraoperatively using low-cost materials, seen here. The full recipe, including the materials, is listed explicitly in our abstract found in the meeting program, so I'm not going to list the details here. But one of the unique aspects of the study I want to highlight is the simplicity of both the materials used and the assembly technique. So this allowed the surgical technicians to not only learn how to make the coated nail, but also to consistently reproduce them independently, which allowed the attending surgeon to concurrently proceed with other parts of the procedure. So what do we find? Well, 32 patients were included for analysis, and the most common index injury location was tibia fractures, over 50% of which were open at the time of index injury. 22% of the patients in the cohort were treated for an acute infection, and the remaining were treated for an infected non-union. One-third of the patients receiving an antibiotic-coated locked nail required at least one unplanned reoperation. Indications for that reoperation included recurrent or persistent infection, a new non-union, or a recurrent or a persistent non-union or malunion repair. But this also means that the use of the antibiotic-coated nail successfully treated deep infection and ununited fractures in 76% of the patients with a single surgery. So the first concern when any new surgical technique or implant is introduced is obviously patient safety. So during our study, while there were no immediate or obvious complications noted during production or insertion of the antibiotic-coated nails, second and even third order consequences should be considered because, as we saw, some of these patients still required a reoperation. One problem reported in the literature is cement delamination or debonding during the coated IM nail extraction or insertion, which can leave free bits of cement in the canal. Reports of this are uncommon, but possibly underreported due to inadequate operative documentation of surgical complications. The next obvious question regarding new surgical techniques is, does it work? And also importantly, does it work as expected or intended? So I'm happy to report that results so far are very promising. Based on our results and some of the pioneers of this technique, like Janet Conway, who published on it way back in 2007, And one of the important findings being that the total number of operations per patient was significantly decreased, thereby increasing the value of care we can provide to each patient and potentially shorten the total duration of treatment. So if the multi-stage approach has been proven effective at treating infection, then why change our strategy? Using total number of surgeries per patient as a proxy for total cost of care, the single stage approach using a coated nail obviously decreases cost. But aside from the financial benefit, just practically speaking, many patients would likely appreciate the option to attempt treatment using a single stage approach with a coated nail in hopes of foregoing an additional operation and begin the healing process sooner, especially if there's minimal downsides to trying. One detail of the study that I do want to highlight is worth mentioning is that both fracture healing and infection type varied in time amongst our cohort. So patients with acute and chronic infections, fresh and old fractures were all included, which may increase the variance of our results. But one strength, as I mentioned, is the utilization of low-cost materials and a repeatable technique. So in conclusion, based on our results compounded upon those before us, we believe that single-stage antibiotic-coated locked nailing is safe and effective treatment strategy for fracture-related infections, with more indications for use expanding on the horizon. Thank you for your time and attention.